Thank you for that introduction. As you said, my name is Ashley Wilde. I'm an infectious diseases pharmacist by training. And I have worked at Norton Healthcare as a lead for our antimicrobial stewardship program for almost 12 years now. And I'm happy today to talk about antimicrobial stewardship in pneumonia. So my relevant financial disclosures are listed on this slide. I do serve as a co-principal investigator for an RSV epidemiology study that is sponsored by Pfizer. However, there is no financial interests or other relationships relative to the content that I'm going to be presenting today. Other important disclosures, yes, I am tall, I am 6'1", and no, I do not play basketball. So those are the typical questions that I get, so we'll just get those out of the way, and we can ask some, I guess, stewardship questions at the end. So my objectives for this presentation are for you to be able to describe the opportunities to apply antimicrobial stewardship principles in the management of pneumonia, as well as define the rate of bacterial co-infection in patients hospitalized with COVID-19 pneumonia. So I want to take a little history lesson before we get started to talk about stewardship and talk about acute bacterial pneumonia classification. So I can see in the audience we've got a variety of age groups represented, but I do really want to take a step back and talk about a time where we had two guidelines prominent from the Infectious Diseases Society of America that classified the types of bacterial pneumonias. So for a period of time, we had one guideline from the American Thoracic Society and IDSA focusing on community-acquired pneumonia. And then we had another guideline that was the HCAP, HAP, VAP guideline, where we clustered those three types of pneumonia and talked about them relatively similar to each other. Now, it's important to classify pneumonias because the etiology is really defined by what type of pneumonia that we're talking about. And the epidemiology is driven by two really important bacteria, first being MRSA, and the second is multi-drug resistant gram-negatives, particularly Pseudomonas aeruginosa. So when we talk about epidemiology and then the empiric antibiotic selections that drive this, we really need to focus on, well, who's at risk for MRSA and who's at risk for Pseudomonas? And what was also really important at the time, back when we had these two guidelines, the CAP guidelines and then the HCAP, HAP, and VAP guidelines, is that there was a core measure focusing on adult patients with community-acquired pneumonia, where you had to select the correct antibiotics within 24 hours. And anytime there's a core measure on anything, especially those who have some administrative responsibilities, know that this can be very important that we quickly define and document which type of pneumonia we are talking about. And so a lot of times when I talk to especially newer clinicians, and they're like, I don't know why people keep talking about HCAP. That hasn't been a thing. Well, it's because it was really driven into people's minds that if a patient had HCAP instead of CAP, so healthcare-associated pneumonia, then they didn't have to fall into this CAP core measure. So what happened, though, was that in 2016, the IDSA updated their guideline and released a management of adults with HAP and VAP. And what was really important to note was that HCAP was no longer mentioned in their guidelines. And the reason for this was after they realized that so many patients fell into that bucket of HCAP, that really the epidemiology around MRSA and multi-drug resistant gram-negatives like Pseudomonas didn't really happen that frequently. And what we were seeing were lots and lots of patients getting unnecessarily broad antibiotics. And the consequences of that, including C. diff and driving drug-resistant gram-negative infections in particular, was really problematic. So they said, you know what? HAP, VAP, that's really going to be driven by what organisms are in your hospital. HCAP, by the nature of it being a healthcare associated, we're still patients in the community, so we're gonna let the CAP guidelines take care of HCAP from now on. And so we existed in limbo for this period of time between 2016 and what ultimately was the 2019 release of the IDSA guidelines in community-acquired pneumonia. And what they said is, you know what, HCAP, that's no longer a thing. We're just gonna define patients who have community-acquired pneumonia and identify that some of these patients are at risk for more drug-resistant organisms. So where we sit today is we have community-acquired pneumonia, we have patients who have risk factors and whose don't, and then we have hospital-acquired pneumonia and ventilator-associated pneumonia. And before I talk about risk factors that build upon this, I do want to just talk about the routine epidemiology when we're building empiric antibiotic regimens about what you have to cover at baseline for adults with CAP. So for CAP, we're going to focus on Streptococcus pneumoniae, as well as atypical organisms like Legionella. At a minimum, your empiric antibiotic regimen should have activity against these. For patients who have HAP or VAP, at a minimum, they need empiric activity against MSSA, so methicillin-susceptible Staph aureus, as well as Pseudomonas aeruginosa, although they identify that it's not necessarily a multi-drug resistant Pseudomonas aeruginosa. And a quick note, just because it's addressed here in the epidemiology, but I'm not going to be talking about it in detail in the rest of my presentation, is that these guidelines also note that anaerobic coverage is not necessary unless lung abscesses or empyemas are suspected. The old Mandel literature in infectious diseases really focuses on the etiology of aspiration pneumonia, primarily focusing on people who do have lung abscesses, where anaerobes are far more common. But if you think about it, almost all acute bacterial pneumonias are aspiration pneumonias. You have colonization of the upper airway that then translocates down into lower airways to develop acute pneumonia. So if you have a micro or macro aspiration event, adjusting the epidemiology for your coverage empirically may not be necessary. So I mentioned for CAP and HAP and VAP, we have our routine everyday bugs that we want to make sure we have at minimum activity. Now you might be saying, well, hold on, there's other bugs that can cause these infections, and of course they can. But when we're talking about empiric antibiotic selection, you want to pick something that has at least activity against these, and typically you will get a wide variety of other organisms as long as your empiric antibiotics have activities against these bugs. So is broader therapy needed for anybody who has community-acquired pneumonia? And the answer, of course, is our favorite thing to say in infectious diseases, which it depends, right? So not all patients with healthcare-associated, hospital-acquired pneumonia need broad therapy, and not all patients with community-acquired pneumonia need broad therapy. And the guidelines do try to provide some guidance that is a little bit more sophisticated than what our previous guidelines said. Particularly around HCAP, HAP, and VAP, they tried to say, look, your patients are going to die. These pneumonias are so severe. You need to start really, really broad up front. But instead, the guidelines try to provide a little bit more individualized approach. So for patients who have community-acquired pneumonia that is not severe, and typically we think about severe as, are they in the ICU or in septic shock or not? But the IDSA guidelines do provide a more detailed definition of what they consider severe if you want to review their references. But those patients who are admitted to the floor with community-acquired pneumonia, regardless of healthcare exposure in the past, the recommendation is that you need to start empiric MRSA activity only in patients who have a prior respiratory isolate of that was MRSA. So if you have a skin infection, it may not be necessary to start empirically on pneumonia therapy for MRSA, or if they have a nasal MRSA PCR that's positive. Similarly, when it comes to anti-Pseudomonals, their only risk factor that they identify that warrants empiric activity against Pseudomonas is those who have a prior history of Pseudomonas aeruginosa from a respiratory isolate. Now, if you have a patient with community-acquired pneumonia that's admitted to the ICU, there are more risk factors, which makes sense, right? We want to be less cavalier about narrow-spectrum therapy empirically when somebody has severe community-acquired pneumonia. For empiric MRSA, they recommend both prior isolation, but they also say recent hospitalization, prior IV antibiotics in the last 90 days, which sounds very reminiscent of that HCAP definition that we used to use. But then they also throw in this one that I think is particularly challenging, which is a locally validated risk factor. That's essentially what the IDSA is trying to do, is trying to say, I don't know where your MRSA prevalence looks like in your community, so you guys could just figure it out and you guys decide which patients are at higher risk. This is very challenging to do, particularly with changing epidemiologies and risk factors. But they put that in there to say, if you happen to know that your community is particularly high risk for MRSA or a particular patient population, then that would be empirically warranted. So for anti-Pseudomonal therapy, they say, again, prior respiratory isolation of Pseudomonas aeruginosa, recent hospitalization, prior antibiotics in the last 90 days, or locally validated risk factors. So something very similar. For risk factors for multi-drug resistant hospital-acquired pneumonia, there are more recommendations about who should have empiric MRSA activity, or in this case, we're talking about escalating from anti-Pseudomonal monotherapy to potentially dual anti-Pseudomonal activity empirically. So this is where we get into that triple therapy of something like VANC, an anti-Pseudomonal beta-lactam, and a third agent, either a quinolone or an aminoglycoside. So for HAP, so hospital-acquired pneumonia, for MRSA, they say previous IV antibiotics in the last 90 days. If 20% of your Staph aureus isolates in your unit are MRSA, which honestly is most of the United States, There are places in the world that if you get admitted to the hospital and they know you're from the United States, they will put you in isolation because there is so much MRSA in most communities. About 50% of Staph aureus tend to be methicillin resistant. But that's actually not true in other parts of the world. We live in a very endemic community. If you don't know the prevalence of MRSA within your institution, they recommend empirically adding MRSA activity, or if patients are at high risk for mortality, which they define as requiring ventilator support or septic shock. Similarly, if they want to empirically prescribe 2 anti-pseudomonal agents, the only risk factors they identify are those who have previous IV antibiotic use in the last 90 days, or those that are at high risk for mortality. So for ventilator-associated pneumonia, which is the last slide for risk factors, similar themes here as well. So they reduce that threshold for MRSA a little bit lower. So they say, if you have 10 to 20% of your Staph aureus isolates in your unit are methicillin resistant, then it's reasonable to empirically start on an anti-MRSA as opposed to an anti-MSSA therapy, or if the prevalence is unknown. And as far as recommendations on who should receive empiric dual anti-pseudomonal therapy, it's a lot more risk factors. We've got a lot more severity of illness markers that they say, let's not take a risk and let's make sure that we cover all of our bases. And in particular, if at least 10% of your gram-negative isolates are resistant to the beta-lactam that you are choosing, they recommend to go ahead and add another agent. The idea is that the authors of this guidelines are trying to prompt you to prescribe an empiric antibiotic regimen for VAP that covers at least 95% of the likely organisms. And so this idea of like, well, what's the threshold that we should shoot for? When you look at an antibiogram and say, is 50% good enough? I mean, if you feel like you're, the Joker and you want to just, flip a coin potentially, 80% might be appropriate for somebody with a more mild infection. But when we start talking about things like ventilator-associated pneumonia, that threshold as far as what we're looking to cover tends to go higher and higher. So I don't know about you, but I get very confused every time I look at these guidelines and I think about how do you apply these clinically? And it's really interesting because even the authors of the guidelines say, this is really hard to follow. It's really hard to operationalize. They tried to create something that was more nuanced compared to the previous guidelines that said, just give everybody really broad spectrum antibiotics. And so this is where antimicrobial stewardship programs can really come in because they review that local epidemiology. They develop empiric treatment guidelines based off of that epidemiology. They monitor patients to assist with de-escalation. So even if we started broad, we can change therapy to something more narrow. And they also can keep track of duration of therapy and make recommendations when time's up. I know that this, even with modern EMRs, can be really challenging because patients get antibiotics in the emergency department. Then they get started on something in the hospital, and maybe we have to put in a new order because we either switched drugs or their renal function changed. So now keeping track of what day of therapy we're on can get lost in the shuffle. And that brings me to my next point about applying antimicrobial stewardship principles to pneumonia, and that's the question of how long should we treat CAP? I start with CAP just because it's something that's so common, and the IDSA and ATS guidelines say we should treat for at least 5 days. And they say 5 days really is that magic number for patients with hospitalized for a community-acquired pneumonia. They recommend that you treat for at least 5 days as long as the patients have achieved clinical stability. So their definition of clinical stability means they have normal vital signs, they're eating, and they've achieved what is their baseline normal mental status. So note that nothing here says they have to have resolution of their cough, or their symptoms have gone away, or their chest x-ray is improved. Because those types of things, as we studied over and over again in infectious diseases, tend to be lagging indicators and aren't necessarily indicative of ongoing bacterial replication. They say if you not achieve clinical stability by day 5 to continue therapy. However, I will also point out that if somebody has not achieved clinical stability by day 5 on an empiric CAP regimen, you're going to want to start thinking about whether or not we missed an organism or there's an alternative diagnosis, since most patients will achieve clinical stability usually by day 2 or 3.
So are you talking about, excuse me, are you talking about just that we continue them on the IV, or are we talking about, hey, we're 24 hours out, you're stable, you're going home on 3 to 4 more days by the PO antibiotics?
That's total days of therapy. Yep. So I want to take a moment to talk about a randomized trial that really confirms that 5 days is in fact an ideal length of therapy. So a lot of times in infectious diseases, we have to rely on small retrospective studies, but we actually have a well-powered prospective randomized clinical trial that focuses on the duration of therapy for patients with community-acquired pneumonia. So adults that were admitted with CAP who achieved clinical stability for at least 48 hours at day 5 were randomized either to stop antibiotics at that moment or let the physician decide length of therapy. And as you can see, we had 146 patients in the stop antibiotics arm, as well as 137 patients in the physician discretion arm. And what we saw, as you can imagine, was that the median duration of therapy for patients who were stopped on 5 days was in fact 5 days. And the median duration of therapy of antibiotics for those that were left to clinicians' discretion was 10 days of antibiotics. So when it comes to outcomes in the 5 days versus 10 days arm, we saw early clinical success in 56% of patients who were at 5 days of therapy, as well as 48.6% at 10 days. They did reevaluate this endpoint at 30 days and saw very high clinical success rates in both arms. They saw overall low hospital mortality, as well as 30-day mortality that were not different between the groups. In this clinical trial, there were a few patient populations that were not evaluated, such as those that were immunocompromised, which present a wide range of problems relative to their severity of their immunocompromise and their underlying comorbidities. They did not include patients who are at risk for Pseudomonas or who needed a chest tube, so patients who had significant pleural effusions were not included in the study. They did not include patients who were pregnant or breastfeeding or who had failed previous antibiotics. They also did not include anybody who had pneumonia that was complicated by another site of infection like meningitis or endocarditis. But the key takeaway of this is that 5 days of antibiotics is just as effective as longer courses of therapy. Now, I snuck in this next slide at the last minute because I'm a little bit of a Brad Spellberg fangirl. And for those of you who don't know who Dr. Spellberg is, he is an infectious diseases physician out in Southern California, and he is a big advocate and researcher on antibiotic stewardship. And he actually maintains this website, and if you Google infectious diseases, shorter is better, he meticulously keeps track of these publications and how many publications in which patient populations have demonstrated that shorter is just as good as longer therapy. And I want to point out in community-acquired pneumonia, there's actually 14 randomized clinical trials looking at shorter durations of therapy being just as good as longer durations of therapy. So this is not just, the IDSA thinking, well, this might apply to just a few patients, but in fact has been studied again and again. Like I said, this website, if you ever want to go and look at the references, has a lot of other literature on there about other disease states that I'm not touching on today, like pyelonephritis and complicated urinary tract infections, intra-abdominal infections. But Dr. Spellberg really tries to fight the dogma associated with longer durations being better, and he's really coined this mantra that shorter is better. And I do want to take one more moment, and again, I snuck these slides in last minute today, but for those of you who are focusing on antibiotic stewardship, we tend to have a very laser vision on the inpatient, but a moment of weakness that I want to make sure everybody aware of is duration of therapy at discharge. So these are actually slides from a study we did at Norton Healthcare where we retrospectively reviewed patients who are at least 18 years of old who were admitted for community-acquired pneumonia based off of their ICD-10 diagnosis code. And we looked at their total length of therapy as well as the length of therapy at discharge. And we used discharge as a surrogate marker to say that we assume that you've achieved clinical stability enough to go home. What we found is that the median length of therapy was 9.5 days, and the median discharge length of therapy was 5 days. And I can show you how that was distributed. So this is the total duration of therapy for community somebody who is admitted for 24 hours. You might only need to prescribe them 4 more days to go home on. But there is something very comforting about using 7, 10, 5, 14, whatever it may be. We've noticed that 76% of our patients were discharged on either 5, 7, or 10 days of antibiotic therapy. So for those of you who are discharging a lot of patients and are responsible for that decision making in that moment when you're sending your patients home, do recognize that most patients who have achieved clinical stability and are ready for discharge likely only need 1 or 2 days of therapy and don't need an entire new course at discharge. This is a huge blind spot in the world of antimicrobial stewardship because it really focuses on ambulatory stewardship, but we're not alone in identifying this finding that most patients who are admitted for their entire course of community-acquired pneumonia do really well as far as following a lot of the guidelines, but this is definitely a blind spot in a lot of people's prescribing. So I want to take a moment and shift back to how long we should treat ventilator-associated pneumonia. This is actually a question that we've had good evidence for a lot longer than we've had for community-acquired pneumonia. In fact, this study, which is a comparison of 8 versus 15 days, was really a hallmark trial that was published back in 2003, so it's almost 20 years old at this point, but it was a really well done study to help define whether 7 days of therapy, which was then stopped on day 8, or 14 days of therapy was better for patients with ventilator-associated pneumonia. And I will say that most of our literature on how long to treat hospital-acquired pneumonia is actually extrapolated from ventilator-associated pneumonia studies. But in this study of 8 versus 15 by Shastra, we saw that a short course was associated with increased 28-day antibiotic-free days, which makes sense because if you are stopping antibiotics sooner, you're going to have more antibiotic-free days within the first month. And they also saw a reduced recurrent VAP due to multi-drug resistant organisms. So in ventilator-associated pneumonia, we do have a small percentage of patients who do get a secondary pneumonia or a superinfection. But what we saw is that if we stopped antibiotics in that first week, that when they get a superinfection on top of it, it is less likely to be a multi-drug resistant organism. Between the two groups, we saw no difference in mortality. We saw no difference in recurrence. No difference in treatment failure, hospital length of stay, or duration of mechanical ventilation. Like I said, this was a really well-performed randomized study, so we could thankfully put this issue to rest very early on. But there was this additional caveat from that study 20 years ago about non-lactose fermenting gram-negative rods, which is a very fancy way to say Pseudomonas or Acinetobacter. And what they saw in their randomized trials that patients who got short course therapy for those particular bugs didn't do quite as well as compared to long therapy. And of course, the study wasn't necessarily designed to look at those and tease out why they might have performed worse or better, since there isn't necessarily anything inherently different about those bacteria. Maybe the antibiotics we had at the time weren't dosed appropriately or weren't as effective as we thought. But since then, there have been 2 meta-analyses that looked at specifically duration of therapy in hospital-acquired or ventilator-associated pneumonia. And in fact, when the IDSA published their update to the HAP-VAP guideline, they went ahead and did their own meta-analyses specifically looking at short versus long course therapy for non-lactose fermenters, and they actually saw no difference in outcomes when they looked at the data again. So this study, again, that's 20 years old, kind of gave us a little bit of pause about what to do around Pseudomonas or Acinetobacter, but since then the guidelines have said we haven't been able to replicate that data and we should treat them the same. Now, the reason I talk about these short versus long, and you guys might be thinking, well, in the grand scheme of things, you know, what's a few more days, right? Dr. Spellberg, who I mentioned works a lot in dispelling dogma related to antibiotic stewardship, really challenges providers about their perceptions on antibiotics, about whether or not antibiotics are making the patient better or if they're making the prescriber feel better. He says that antibiotics are the best anxiolytics for providers, right? Because it makes them feel better knowing that the patient is on something. But I really challenge people about every dose, because every day matters. This study, which was done out of Barnes-Jewish, looked at the risk of development of drug-resistant organisms based off of the duration of anti-pseudomonal beta-lactams. It was a very nicely done, contained study looking at patients, of over 7,000 patients who were admitted to their ICU with either severe sepsis or septic shock. And they focused on 3 beta-lactams, cefepime, piptazo, and meropenem, just to keep it, again, really commonplace and contained. And what they did is they looked at the development of new resistance to one of those antibiotics within 60 days of receiving those antibiotics. And what they saw was that for each additional day of therapy that that patient received, there was a small but statistically significant increase in the risk of development of multi-drug resistant organisms. So oftentimes providers hear this recommendation of 5 days, and they're like, great, 5 days. I'll just add 2 more, just to be case, right? Just in case, make it 7. Or we say, hey, it's 7 days of therapy is recommended. Well, let's just add 3 more and make it 10 days of therapy. There's this compulsion to say, well, just in case, we're going to extend the duration a little bit longer. But what I'm trying to implore is that each additional day, you are putting the patient at increased risk without evidence supporting that you're getting significant clinical benefit. And I never know for each individual patient who's that patient that's going to get C. diff, or who's that patient that's going to end up with a multi-drug resistant infection. I don't have a crystal ball, and thankfully most patients do not get harmed, but what we do know is that you are playing roulette every day that they receive antibiotics. So that really is my last take-home point when it comes to antibiotic therapy for acute bacterial pneumonia. And I did want to shift gears for a little bit and talk about everybody's least favorite kind of pneumonia, which is COVID-19. And I promise I'm not going to be talking about how to treat COVID-19 because I don't think anybody wants to hear about that, but I do want to talk a little bit about how we can apply antimicrobial stewardship principles in COVID-19. And I want to talk a little bit about how antimicrobial stewardship programs were impacted because of the pandemic and what impact that it had on antimicrobial resistance. So for many of you, when the pandemic hit, your day job might have gone a little bit out of the window. You know, I actually happen to work with somebody who studies respiratory infections as his entire career, defines himself as a pneumonologist, so he was having the time of his life. Everybody else was pretty miserable. We were all pulled from most of our day-to-day activities and instead having to focus on the pandemic. And people who do antimicrobial stewardship got diverted towards COVID-19 as well, which you might think, well, of course, it's infectious diseases work. But it's actually not inherently rational because antimicrobial stewardship is all about the prevention of unintended consequences. Right? We weren't really talking about drug-resistant SARS-CoV-2. I mean, we do talk about variants and things like that, but usually we talk about protecting antibiotics in order to protect the pipeline, which I don't know if you guys are all aware, but it's actually been over 3 years since a new antibiotic has been approved by the FDA. 3 years, and we've had no new antibiotics. So when it comes to protecting antibiotics, it is really, really important because we just do not have new therapies coming. But a lot of core antimicrobial stewardship activities like reviewing patients, restricting low-risk or high-risk or low supply or high-risk antibiotics, performing timeouts to make sure our therapies are still appropriate, and the fact that antimicrobial stewardship workers often engage with microbiology and infection prevention. We often develop guidelines and do a lot of education. You know, a lot of these core antimicrobial stewardship activities were quickly translated into COVID-19 efforts. And you might think, well, that's great. Maybe we didn't need to do antibiotic stewardship because everybody was sick with a virus. And like I said, we didn't really have treatment options, and at the time, we weren't really concerned about antiviral resistance. So maybe it was just, I'll go work on this virus for a minute, and we'll just leave the antibiotics alone. Unfortunately, what we saw was that there were very, very high rates of antibiotic prescribing in COVID-19 early in the pandemic, despite having low rates of bacterial co-infection. So from 3 studies that I just pulled to emphasize, an early publication from Hilary Vaughn's group up in Michigan reported that 56% of patients who were admitted for COVID-19 early in the pandemic received empiric antibiotics, despite only 3.5% of her patients having confirmed community onset bacterial infections. In New York City, where the pandemic hit hard and it hit fast, 70% of patients were started empirically on antibiotics, despite them only identifying a 3 to 8% community onset bacterial co-infection. And last but not least, in one London ICU, 100% of their patients who were admitted for COVID-19 were started empirically on antibiotics, although they only identified 6% of their patients that had a community onset bacterial co-infection. But you know, some things related in the fight of antimicrobial resistance actually were pretty good because of the pandemics. If you guys remember, we had people that were obsessed with hand hygiene, right? We had distilleries that were making hand sanitizer because we just needed hand sanitizer so much. Everybody wanted it. In a lot of hospitals, we limited visitors, which obviously was very sad for those loved ones that were sick, but it really decreased the amount of mingling in common areas and spreading pathogens to vulnerable patients. We also did a whole lot of social distancing. I think everybody probably has some story about hearing somebody completely freak out at Costco or something like that when you accidentally came too close to them. Like, everybody kept their distance, at least for a period of time. And what we also saw was a big uptick in telemedicine. So previously, if you thought you needed care, you would go to an immediate care center or somewhere and you would sit in a lobby full of other sick people just spreading diseases everywhere. And obviously that's not good when we're talking about the spread and development of antimicrobial resistance, or AMR. So good things actually were happening during the pandemic when it comes to infectious diseases. There were some bad things, one of which I already mentioned: widespread antibiotic use and diverted antimicrobial stewardship resources. Particularly in the early days, we didn't have rapid COVID tests, so that being able to quickly identify who does and does not have COVID-19 was challenging. We did have a lot of critically ill patients, and probably the most devastating thing was the lack of PPE to protect our healthcare workers and therefore protect our patients. I don't know what happened here necessarily, but I know at many organizations, they stopped isolating patients who had a history of MRSA because they just needed to use that PPE for patients with COVID-19. So if we said, hey, this is a particularly difficult, MRSA is a resistant organism, we need to make sure we're careful about that. As soon as the pandemic hit, we said, you know what, we're good. We got a lot of MRSA. I think we're gonna let them sit there for now. But the question really remained, where will we fare when it comes to the fight against antimicrobial resistance in COVID-19? We had the good and we had the bad, and of course, we ended up with the ugly. So in 2022, the CDC released a special report highlighting the impact of COVID-19 on our fight against antimicrobial resistance. And what they said was that COVID-19 really did create the perfect storm. They reported nationally a 15% increase in antimicrobial resistant infections and deaths in 2020 compared to 2019. So this isn't even talking about deaths from COVID, this is talking about antimicrobial resistant infections. They note that about 80% of patients hospitalized with COVID-19 in those early months of the pandemic received antibiotics. And so this was obviously a devastating blow to people who work in antimicrobial stewardship, who are really trying to fight the development of drug resistance. And if you guys are micro geeks out there, you'll probably be interested in the specifics about all of the things that really keep me up at night. Like, we saw a 78% increase in carbapenem-resistant Acinetobacter. Carbapenem-resistant Enterobacterales, or CRE, went up by 35%. Another 32% increase in ESBL-producing Enterobacterales. Drug-resistant Pseudomonas also went up by 32%. All of those resistant gram-negatives that I was warning you about earlier, what we saw nationally compared from 2019 to 2020 was big increases. Smaller increases on our gram-positives like MRSA and vancomycin-resistant Enterococcus, but also we saw a big uptick in our antifungal resistance. So 60% increase in Candida auris, as well as 26% increase in antifungal resistant other Candida species. So that's obviously concerning, and the CDC is obviously encouraging people to take a renewed interest and make sure that the ground that we lost during the pandemic is regained. So there is some light at the end of the tunnel. We do have faster COVID-19 tests. We obviously have vaccines and therapeutics, which are keeping people healthier. But we also have a renewed interest in infectious diseases. The CDC, the public, they're like, wow, infectious diseases is important. I'm like, yes, I know. I've been doing this now for most of my adult life. Of course, infectious diseases is important. But what's really nice about this renewed public interest is that we have renewed funding in infectious diseases. So one of the funding sources went towards the SHARP grant, which is the Strengthening HAI and AR program. And HAI stands for Healthcare-Associated Infection and Antimicrobial Resistance. So strengthening our program, focusing on healthcare-associated infections and antimicrobial resistance. And so here in Kentucky, this SHARP grant helped us start CASIC, which was a program that we started last year, which is called the Kentucky Antimicrobial Stewardship Innovation Consortium. And what we are trying to do is provide access to antimicrobial stewardship information and expertise in all acute care or long-term care facilities that have questions or need help or want to work on operationalization or implementation of antimicrobial stewardship tools. So we have a website. If you want to go there, you can also access it from that QR code that's on the slide. You can sign up for free. Everything we do is free. We provide any sort of on-demand education that you might need, individualized to you if you so need it. But we also have a whole and growing library of other resources. So we create educational pearls that we send out every week that are designed to be 2 to 5 minutes of just review and understanding of antimicrobial stewardship concepts. We also have video recordings of some of our grand rounds presentations on both clinical microbiology and antibiotic stewardship. But whatever you need, if you want to go to this website or contact me, we're happy to help you with patient-related issues, program-related issues, or information or technology or whatever it may be. So we're really excited to be able to offer this program since there are so many people that are struggling with the same or similar problems across the state. And unfortunately, they don't have necessarily the time and attention needed to do antimicrobial stewardship. And I want to take one last minute to talk about how we apply antibiotic stewardship principles to patients with COVID-19. And really, there's two types of patients that we can think about when it comes to managing antibiotic stewardship in COVID-19. The first is patients who have a co-infection, so somebody who comes in with both COVID-19 and another concurrent infection, which would be typically community-acquired bacterial pneumonia. And then I want to talk about secondary infections, so what happens when somebody develops COVID-19, gets admitted to the hospital, sticks around for a period of time, and then develops a new infection. So that would typically be hospital-acquired or ventilator-associated pneumonia. So talking first about bacterial co-infections, after review of all the literature, I highlighted some of the incidences before, but what we know now is that bacterial co-infection in patients admitted with COVID-19 is actually quite low. It's actually lower than what we see with some other viruses. Like influenza is actually a little bit higher than this, but what we see is at least less than 10% of patients have a bacterial co-infection. The NIH comes out with a recommendation in their current guidelines saying that they recommend against empiric broad-spectrum antibiotics in patients, even those that have severe or critical COVID-19, but rather suggest taking a more individualized approach, looking at the chest x-ray to look for lobar infiltrates, or obviously confirm microbiological data. For patients who have very severe infections during those first few moments upon hospitalization, it's reasonable to potentially start antibiotics. But the biomarker that we use often to help objectively evaluate whether somebody has a bacterial infection can be applied to COVID-19. So procalcitonins, they get a lot of use and a lot of discussion, and everybody has, I'm sure, has anecdotes and data to support that sometimes patients did have a bacterial infection and they may not have been elevated. But what we saw in COVID-19 with procalcitonin is that the procalcitonins actually can be a little misleading, but not in the way you'd think of when it comes to antibiotic stewardship. We have seen elevated procalcitonins in the absence of confirmed bacterial co-infection. So interpreting an elevated procalcitonin level in somebody with COVID-19 doesn't necessarily mean they need antibiotics and have a secondary bacterial co-infection. However, procalcitonin levels in patients with COVID-19 have a very high negative predictive value. In a study of almost 2,500 patients, they saw 99.3% negative predictive value, meaning if you have a negative procalcitonin, particularly when you get into the day 1 or day 2 of admission, if that procalcitonin level is low, is highly unlikely that there is a secondary bacterial infection. As I mentioned before in the previous slide, just with community-acquired pneumonia in general as well, procalcitonin is not recommended to aid in the decision to initiate antibiotics, but it can be a very useful tool to rapidly discontinue antibiotics. And for me, I like algorithms that help outline your thought process. So in the critical care literature, this algorithm was proposed and makes a lot of sense to me as far as like an approach to those critically ill patients with COVID-19. If you have somebody who's admitted to the ICU with COVID-19, their approach is that if you do not have a patient that is in septic shock or has a focal infiltrate compatible with a bacterial pneumonia on CT scan, instead of the ground glass opacities, if you don't have one of those criteria, they recommend watchful waiting, collecting microbiological data, consider getting seroprocalcitonins, or other appropriate rapid diagnostics. However, if they are admitted with septic shock or have that focal infiltrate, to go ahead and initiate antibiotic therapy, but obtain appropriate microbiological samplings. And of course, follow your own guidelines when it comes to the epidemiology, since there isn't anything that we know of yet that says COVID-19 predisposes patients to any other abnormal etiologies. And then, as you can see here, they also said go ahead and treat for 5 to 7 days. When it comes to secondary infections, and fortunately, I said fortunately, not unfortunately, these are becoming less common and less problematic. But there were a lot of patients who were admitted for COVID-19 that developed ARDS, right? And then they were on the ventilator. They were sick for a long period of time. Our recommendations, and this is this is a lot of how we approach it from an antibiotic stewardship perspective for patients that potentially have a secondary infection. Is obviously obtaining appropriate cultures. In the HAP-VAP guidelines, they no longer recommend that you go ahead and get an invasive sampling, but rather a tracheal aspirate is okay. But a lot of these patients, if they're on the ventilator already, potentially a BAL is indicated. We often want to look for opportunities to de-escalate in patients with secondary infections. If you have a positive culture, by all means, follow the susceptibility results and select the most narrow effective therapy to make sure that we reduce the duration of broad-spectrum antibiotics. As I mentioned before, every day of broad-spectrum antibiotics increases their risk for development of resistance. If you have somebody with a suspected HAP or VAP that end up having negative cultures, this is obviously like a very tricky situation. However, if you work in infectious diseases, you probably have a tattoo on you somewhere that says "staff doesn't hide." Because this is the mantra that you get taught at a very early age, and I guess it's just a rite of passage, that if you were to have a severe MRSA infection, so somebody with a hospital-acquired or ventilator-associated pneumonia, identifying MRSA on culture is very easy. So staff hiding is unlikely to happen. So in the setting of a negative culture or a mixed respiratory flora or normal flora, or however your microbiology lab reports sort of a mixed culture, going ahead and stopping MRSA activity and anti-pseudomonal activity empirically without a culture-guided de-escalation is reasonable in these patients. It is a little bit harder in critically ill patients to just say, well, we didn't know what's making them sick, so let's just de-escalate therapy. But in these patients, we typically recommend a stepwise approach, because that way you can quickly escalate therapy should their fever curve resume, or if the patient seems like they're decompensating. So in somebody that you might have started empirically on, let's say vancomycin and pip/tazo, starting by let's de-escalating that that vancomycin off, see how they do. If they tolerate that well, go ahead and try and de-escalate that anti-pseudomonal off of something to something more narrow spectrum and see how they do. This way, we are not stuck forever treating empirically for very broad therapy. The other thing I recommend doing in patients with secondary infections, this isn't necessarily unique to COVID-19. All of these things can be applied to any other severe respiratory viruses, but try to define a duration of antibiotics early, right? Because we often want to define the duration of antibiotics based off of clinical response, which is a very reasonable approach for most infections. However, if you are managing a patient with COVID-19 who has now developed ARDS, your clinical markers for success are going to be very much masked by the fact that they have underlying ARDS. So if you identify somebody with HAP or particularly VAP, and you start them on appropriate antibiotics, you get a microbiological sample, it tells you exactly what pathogen it is, you de-escalate usually within that 48 to 72 hour mark, going ahead and saying, let's set a stop date for 7 days. That way when you reach that 7-day mark, you're not tempted to say, well, just a few more days, because chances are they're still going to be on the ventilator, right? So the fact that they are not well and doing cartwheels out of your hospital should not be the marker that we use to define duration of therapy. And pre-agreeing early on does eliminate that decision in the moment, because when they are still sick, there is a great desire to not want to stop antibiotics. But if you say, we've identified the pathogen, we're going to set a reasonable course, that way we can stop the therapy. And if you remember again, patients with ventilator-associated pneumonia do sometimes get secondary infections. And what you are doing by adding that stop date early is actually protecting them so that if they were to get a secondary VAP, that they would less likely to be multi-drug resistant. And the last thing I'll say about secondary infections is that just because you are not giving them antibiotics does not mean you are not doing something for the patient. So I mentioned antibiotics tend to be much anxiolytics, but they can also be anxiolytics for family members because they want to see you doing something for their loved ones, particularly with COVID-19 and there's long recovery periods. Being able to show that you are doing something feels like the right thing to do, but doing nothing is still doing something. And so when I educate providers about communications on antibiotic decision-making, I often talk about, we are not doing nothing. We are monitoring them off of antibiotics. We are keeping a close eye on them and monitoring their clinical progress while they're not receiving antibiotic therapy. We are still carefully watching them and making sure that we have made an appropriate decision that antibiotics will cause more harm than good for their loved ones or their patient. So the idea that we're not treating them is not necessarily true, but at that moment, we need to protect our patients from the development and the side effects that can be caused by antibiotics. So I will get off my soapbox about antibiotics with one last conclusion slide. I just want to make sure you guys understand that the etiology of acute bacterial pneumonia, it does vary greatly, and there may not be like one size that fits all, but you really should apply antibiotic stewardship principles in the management of pneumonia to help mitigate the development of MDROs. So using the most narrow spectrum empiric option, using order sets can be really helpful with this because they've really teased out the risk factors and selected antibiotics based off of local resistance pattern that will get you to that appropriate mark. Make sure you de-escalate based off of the culture results and use the shortest duration of antibiotics possible, which for most patients with community-acquired pneumonia is 5 days total, including discharge, and 7 days for HAP or VAP. And make sure that we discontinue antibiotics in patients with viral pneumonia where appropriate. So with that, I thank you for your attention. And at this point, if you guys have any questions, I will be happy to answer them.